You're welcome. But I also am reminded of the previous comment. It's not an IT problem, it's a system change problem. So Benard, it is your floor. Thank you.
Thank you. I meant to apologize earlier for coming late and missing some of the first speakers, but I'm happy that I got here. Amtrak did go through the snow and got here pretty reasonably. So I threw together some slides on the train this morning and emailed them. So these are sort of just-in-time slides, and so it'll help me just focus my thoughts a little in reaction. I appreciated your talk very much, and I'm going to say some of the things I think that Darren said earlier, so forgive me for that. So I guess the areas that I would like to comment on about how to make this better is the issue of information overload, which you addressed. What about tools for patients to take home? What about the unfinished business of the admission? I find one of the things that happens at discharge, we all know this, is that there's a lot of stuff that's stopped mid-course, and the question is how to communicate that to the patient and how does that become part of the plan. And focusing on resources at home and community and unanticipated problems that are going to occur after discharge. And finally, the issue, very briefly, the issue of universal versus patient and condition-specific discharge instructions. So start with information overload. That is the health literacy part, just in case people didn't understand this. And this will just continue my tirade from earlier in the morning. You know, I think we've said this, how do we get, what are the most important actions that the patient needs to take and that are, you know, needs to do, needs to know. And I think Betsy, Margaret before had mentioned maybe we should put that up front, and then if we have to have all this information, at least there's something in the beginning that patients can use and understand. But I'm intrigued by the checklist that you mentioned as to whether that could be a way, if that could be incorporated into a checklist, and the patient doesn't necessarily have to bring it from home. Maybe we have to give them that checklist when they get admitted, and they can be using that checklist during their admission. I think sometimes something that gets lost in discharge instructions is what's different from usual. What does the patient need to change from before they were admitted? We often give them a lot of information about what they're supposed to be doing, but it's not often clear, it's not always clear, how is this change from before I was admitted to the hospital? I'm thinking of children with asthma. You know, what's really different now? Focusing on what's different rather than giving just the straight information. Of course, does the patient understand? Darren mentioned teach back, but nobody uses teach back. I feel I have to continue to mention that we give patients a lot of information at discharge and rarely really check in an effective way whether they understand any of it. Then I think later in the afternoon we may be hearing something about calling patients after discharge to check in with them. But a number of people have mentioned that this is a low cognitive period for most patients for a variety of reasons. And there's also a lot of anxiety going on, which may be impacting their ability to understand. And they're going to have those questions when they arrive home. And the system should build in some, I would suggest the system should build in some sort of communication with the patient, a check-in after they're home for some period of time. And finally, in discharge, including in your presentation, it was a focus on patient, when should they call us back, when should they contact us, and I think that's a critical aspect, and again, specific reasons for them that are outlined as to when they should contact us, and also having them understand the reality of the contact, giving them the ward number, which we often do, or the emergency room number, or an office number where there will be nobody there when they call, you know, is going to just be frustrating for them. So to sort of think about how will they be able to contact somebody who actually knows about them and their case. Perhaps that is the primary care physician in the community, but then that gets to your point about how do we communicate effectively prior to discharge to the primary care physician so they're empowered to be able to help the patient if that's who we're signing off to. Tools for the patient to take home, just a brief thing. I'm going to focus a little on written asthma action plans, big in pediatrics. This is a requirement on discharge, probably for adults as well as kids, but I'm focusing on, my experience has been with kids. We have to give everybody an asthma action plan who's an asthmatic. There are also medication administration or medication taking tools. We should be thinking, this is not an IT solution. On the other hand, communicating can use IT. Every one of my patients has a smartphone, even if they're homeless. Everybody has a smartphone. So being able to use a smartphone as a communication, being able to use video components, I think are really important tools that we can build into the discharge instructions that will really help. And I know that people are beginning to study this, including us. So I'm just going to briefly talk about for 2 minutes on the asthma action plan. So there are concerns about the complexity. These are just 2 asthma action plans. If you can't read this, neither can the patients. They're color coded. There's a lot of information. One is a kind of check off kind of form. There's just, again, these are just 2 of many, many asthma action plans. So in reaction to this, some of us have been trying to sort of redesign it. And again, although our focus is on low literacy patients, I would submit that no patient will find this. This is a universal issue. So somehow, okay. So this is our redesigned form, and I think I skipped something. No, I didn't. Okay. So this is low literacy, but it actually uses actual pictures of the medications they're going to be using, shades it for day and night. The sick part in yellow is the hardest part to figure out what to do because they're also supposed to be taking their daily medications. And sometimes when you discharge them because they're sick, still you've increased their regular daily medications. So I'm not going to get into detail, but you'll see the concept here is that while they're sick, you also have to tell them that they need to take their daily medications and focus them on an increase if it's there. And of course, what to do in an emergency. So this gives you a sense, and we're testing this out to see if this improves understanding and also outcomes. We've also designed a web-based, which is integrated into the EMR order entry system so that the doctors can actually, the discharge system, the doctors can actually put in the information on the web that individualizes it and then print out the form. Again, some of this should be interactive. We should be able to send this out to a smartphone. They should, so for example, they can, where it says inhale something, we have actually developed a video that if they click on that, they'll be able to be connected to the video, which will show them how to actually give their children the inhaled medications. The point of this is not necessarily to focus on this, but to focus on the concepts of connecting tools to the discharge planning process, making those tools individualized to the patient, using pictures for everybody. I think, we worry about our patients, but frankly, I think this would be better for everybody. And connecting it electronically to videos or other tools that people can access on their smartphones or other technology on their iPads. But smartphones, I think, is the universal platform. In the interim, since this is not done, I think we're going to give patients pictogram-based medications on how to do things which would facilitate what they're doing. That's English, that's Spanish, just we have everything. I want to just comment that Spanish being the major other language in this country, I have patients who speak 70, from 70 different countries, so I can't make things in 40 different languages, but I can at least make things in Spanish for them. This is the issue of unfinished business. So this, I think, is a really important issue. Patients get discharged. Yeah, I'm almost done. Patients get discharged in the midst of their care. The care is not over. And often there are lab results that are still pending. The famous, I don't know, you probably all know of the famous Rory Staunton case, kid who came in to at NYU Langone to the emergency room. A number of issues in the care, perhaps in the care there, but one of the big issues was that there was a CBC that was sent on him, a blood count. Oh, yeah, right. A blood count, a white blood count that was sent for him looking for source of infection. And he was discharged before the blood count came back. And there were, like all medical errors, there are multiple errors that happened at the same time for that to have missed. But there wasn't a clear plan about who was following up on that and what was going to be done with that. And so nobody did. And, the white blood count, which could be high in infection, was somewhat high, but not actually that worrisome. But the band count, which is the immature white cells, which can mean serious infection, was over 50%. And again, had somebody looked at that, they might have said, maybe we should call him back, maybe we should do something, maybe we were wrong in our assessment. And nobody did. So, but this happens all the time on discharge. Every time I discharge a patient, there are usually some labs, often, I shouldn't say every time, often there are some labs that are, and then we think we make a plan, perhaps, of who's following up, who's communicating to the patient, and who's communicating to the physician who's seeing him on the outside. So I think that's an important issue. Again, treatments that need to be arranged. This is further workup as an outpatient. Often we send them home saying the following things need to be arranged, or we will arrange it, or somebody will arrange it. Those things often don't happen as part of discharge planning, and the patient doesn't necessarily get those evaluations in a timely manner. And then often what patients really want to understand about certain diseases certainly is, so what's really going to happen to me in the long run? And we tend to focus in the short run. And as we should, we have to focus on what they need to do in the next couple of days, the next couple of weeks before their primary care provider. But I often find if I ask patients questions that one of the things they really want to understand that we don't tell them about as part of discharge planning is, so how long is it really going to take for me to be able to go back to school? How long is it going to take for me to be able to play ball again? How is it going to be, or for adult, obviously, it would be going back to work, all the way to more serious outcomes. And what are our responsibilities? And so the ultimate question here really is for us to decide, getting back to, I think, your first slide, which is how much of this is our responsibility, and how do we decide if it's not our responsibility, who is going to be doing that for the patient? Very briefly, and I have this and one other slide, and I'll be stopping. So I find that things often fall apart when the patients go home because of some detail that was not addressed in their own home and community resources. Some examples. So I think thinking step by step of practical details. Do they know where the pharmacy is that you're sending them to? I've had patients out the door, and then I ask, so is there any problem? Is your pharmacy near your house? And they say, I have no idea where the pharmacy is, or there is no pharmacy near my house, so I'm going to have to go somewhere else. Well, those are issues that can really affect their ability to get this medicine that you think they should be taking this evening, especially since we often discharge patients now whenever we can, which means often late in the day or even in the evening. Hours of operation. I've had patients go home, and then I find out they never got the medicine because all the pharmacies were closed in their area. I never thought about, so what do I need to do about that? And what should they be doing if they can't get the meds that you're telling them to do? What other responsibilities do they have that may interfere with their carrying out my plan? Like not being able to get a babysitter to watch any of the other kids, or having to go, the husband has to go to work and can't bring them back by car since it's a place with cars. And then financial issues. Do they have the money for the copay? Is there a store nearby that carries or community issues? Is there a store nearby that carries the foods that you're recommending? And of course, these are probably, I live in the middle of a city. These are probably even more concerning in rural areas. So I think practical issues about what they have to do practically when they get home. And then finally, the issue of universal versus patient and condition-specific instructions. I know that just as an example, the hospital discharge for high-risk neonates for NICU patients, there are very specific guidelines of what you need to arrange, what they need to do, and they kind of focus on infant readiness, family and home environment readiness, and community and healthcare system readiness, which I think is a good structure of what has to be done to support a patient in the community. But for those babies, often technology dependent, the universal form wouldn't work. There really would need to be some very specific form, not form, but a system to really help them when they get home. And that's my final. The devil's in the details, I think. I think it's often, I find, the small things in plans that are overlooked that cause serious problems when the patient goes home. And so this gets to the issue of you need to get at the detail level, that double click, I think, that Joshua mentioned. But they can't find that double click in most of our discharge instructions or after visit summaries. And so we have to figure out how they can double click to get to those details.
Thank you.